Hello, good evening, everybody. Thank you for joining us today. My name is Parth, and this is our first ever public health forum that we are organizing. For those who don't know what really Nivarna is a platform which started in July this year, which was mainly like started like a blog initially, which was a place for me to take out my frustration regarding public health in the country and sort of at the same time try to increase awareness regarding various health and social issues in the country. But now it's sort of becoming more of a public health platform where we're trying to bring together public health enthusiasts, public health professionals to sort of address issues, talk about issues, and generally start the conversation around many issues which are not talked about in the country. So this is what Nivarna is all about. Today we are going to be talking about elderly care in India, which I feel is an extremely important topic. As we all know, India is growing older every year. In 2011, the median age of India was around 24.9 years, and it's projected that by 2036, the median age will be 34.7. And the divide between the north and the south is going to widen, with Tamil Nadu being around 40.5 years and UP being around 31 years old by 2036. So as we all know, India is becoming older. We are not really prepared, just like how the COVID exposed our health system. We are not really prepared to deal with the care of elderly people. And that's why today we have with us Dr. Jai Singh Shatri, who is a medical scientist from ICMR Bhubaneswar. His area of interest is geriatric public health. He was awarded the DBT Wellcome Trust India Alliance Clinical and Public Health Fellowship to work on improving geriatric assessment methods in the rural setting. Thank you, Dr. Shatri, for accepting this invite and for being here with us today. I'll just share my screen. To start off with, I have sort of an activity for all of us just to get an idea of what we think. So the topic is going to be elderly care at health and wellness centers. And I request everybody to just sort of scan this QR code, and that will lead them to a website. I hope everybody was able to scan it, or should I share it once again? You can scan this QR code in the left side of the screen. So I just want to understand what you think, what comes to your mind when you think of elderly care, especially in India. So this will sort of build a word cloud around it. So somebody has said neglected. Frailty, important. Neglected is turning out to be the most common theme. Long term. Challenging. Diverse emotional care, something which is often neglected. And actually, like other countries, studies have shown that depression and anxiety in elderly and loneliness is actually a major issue, which is not very well studied in India. Holistic requires research, which is what this forum is going to be all about. Multi-sectoral. So I'm going to close this poll here. So I sort of got an idea of what you guys think when we talk about elderly care, collaborative. So I'm going to hand over to Dr. Shatri now. Dr. Shatri, please take over and take us through this topic.
Thank you, Parth. So, thank you for sharing the slides as well. My voice may be a little low. I have some pharyngitis issues, but I think these headphones should take care of that. So the rationale for this discussion forum has already been explained by Parth. I think it's a good initiative. It has good potential, and I hope this leads to some fruitful collaborations and some public health interventions in the future. It's good to be part of this young group. So, like Parth said, I work in geriatric public health. I am from community medicine background, but I also have a subspecialization in geriatric medicine, and I focus my work in geriatric medicine right now. So, like Parth has mentioned, we have this uh, fairly obvious challenge of an increasing geriatric population. This will be more and more significant in the coming decades, and by 2050, almost 20% of Indians will be older adults, including most of us also, I'm assuming. So that is a very large burden on the health system because this older adult group of population have very unique health needs. The health challenges are more challenges very specific to this age group, such as multimorbidity, which is multiple chronic conditions without an index condition, polypharmacy, mental health issues, disability, frailty. So the field is very vast, and the attention that they need, the medical attention, the public health attention that they need, is also very specialized. We are just beginning to recognize this because historically the focus of our country's public health has been on maternal child health and infectious diseases, mainly malaria, filaria, dengue. Those were the main killers of our productive age groups in the past, and hence, rightly so, the focus was on those. However, with an increasing resource pool that we have right now, in terms of manpower, in terms of funds, this is being diversified, and the uh, burden due to non-communicable disease and aging related issues is now significantly higher, and hence is getting the attention it deserves from the policymakers at the national and state level. Due to their very unique health needs, this group of older adults require multidisciplinary approach, something that primary care is best suited for instead of a highly specialized and system based approach. These all issues have been recognized by the national policy for older persons that came out about the turn of the millennium, and that then led to the development of the national program for healthcare of the elderly. And now what today we will discuss, so these two policies, this is a policy, this is a program, and today what we are discussing are the operationalization of these principles. So these are two policies and programs that are already in place. They had very broad mandate, and they have been trying to mainly bring focus onto this issue. However, with the initiation of Ayushman Bharat and the subsuming of all other health programs into this Ayushman Bharat as an umbrella scheme, comprehensive geriatric care is one of the service packages that is envisaged to be delivered through health and wellness centers that are being built as part of the Ayushman Bharat program. So today we will go through that specific health and wellness center packages or service packages, or what is the vision of service delivery for older adults in the coming decades, if not more than that. So this program for operational convenience have classified older adults into either mobile elderly, those with restricted mobility, or those who are bed bound. There are other ways of classifying older adults as well. Uh, some classifications tend to fixate on age groups, young, old, very old, things like that. Some classifications are based on the diseases that they have or the health related challenges that they face, single disease, multiple disease, and so on. and some classifications are relying heavily on frailty. The recent ones are more dependent on frailty, which are more in vogue in the Western setups, where these concepts are more widely used. But for our operational convenience, because we have a multiple layers of healthcare provision that is being planned, the classification that the program adopts is mobile, restricted mobility, and bedbound. Next. So like I said, there are 4 service delivery levels proposed. The first is the individual or the family or community level. The main services are at this level will be given by the ASHA workers and augmented by the auxiliary nurse midwives. In some states, they are called health worker females, and the community health officers. So these community health officers are an addition in Ayushman Bharat scheme, where they are supposed to be the primary care providers at the health and wellness centers of sub-center level. So the second tier of service delivery is the health and wellness center of sub-centers, where the community health officer, along with his or her primary care team, will be providing this service. The third tier is the existing primary health care centers or urban PHCs, where medical officers are posted and they will provide clinical care to these patients. And the last and highest level are secondary and tertiary care, where specialists are there for consultation, and they will be involved mainly in managing referred patients. So the program even envisages downstream and upstream referral mechanism, where once the community-based elderly are mobilized or identified by the ASHA workers, they will be screened for related any health-related issues by the sub-center health and wellness centers. They will be then referred, if required, to the PHC level and then to the CHC or specialist care level. And the important thing here is the requirement for a down referral system, where everyone will then refer back to the health and wellness center of sub-center, which becomes kind of the focal point which decides up referral or down referral. Next, please. Now, briefly, the guidelines are not that large. So briefly, to cover the role of ASHA workers in this scheme, ASHA workers have are slowly becoming the linchpin of our health system, and even for this program, it relies heavily on ASHA workers carrying out household visits and identifying elderly who require assistance or care at the community level. So definitely ASHA workers are being overworked, and we have to find some ways of mitigating this aspect and synchronizing their other activities so that we don't burden them with additional work. So in this particular scheme, the ASHA workers will be carrying out household visits. They will carry out risk assessments. They will conduct some counselings if required. They will generate awareness. They will importantly identify elderly people who are in need for care, apart from mapping the elderly population in their village or region. They will provide support to family as well, and they will identify caregivers and train them and link them to the healthcare facility if required. There are some other aspects as well, but the important thing is, apart from all these things, the most labor intensive and most important role provided to the ASHA worker is identifying elderly individuals who are in need for attention and healthcare at the community by household visits. So this is the crucial role of ASHA workers in this program. Next, please. The role of community health officer, who will basically be a nursing professional who will be trained in some clinical management aspects of chronic conditions and some aspects of public health as well. So he or she will be, mostly it will be a she, because it's a nursing professional, and given the gender dynamics there, mostly it will be a she. but they will be in charge of the health and wellness centers at the sub-center level, which again is the foundation of Ayushman Bharat scheme. They are supposed to carry out comprehensive geriatric assessment of all older adults identified or screened by the ASHA workers and sent to them at least twice a year. They will also provide some primary management of common diseases. They will link up with the medical officers at the primary health center, and they will be allowed to dispense medications that have been prescribed by the MOs. They are also supposed to visit bedbound and restricted mobile elderly to their houses and carry out assessments there. Uh, One important component which has been adopted from the national program of for healthcare of the elderly is rehabilitative services and support for some disability related support for the elderly population, and that has been assigned to the CHOs. Next, please. The medical officers will carry out, so most of these tasks from here onwards has already been outlined in the national program for healthcare of the elderly, such as provision for fixed geriatric clinics, provision for fixed beds at the CHC, provision for MD in geriatric medicine, which was not there when I joined. There were no colleges providing this MD in geriatric medicine, but now under this program, national program for healthcare of elderly, many colleges have started this course and many more are proposing to start. So a dedicated bed strength is allocated, but we are not sure whether it will be sufficient or not. Primary care management is again the medical management is the core competency of medical officers, and they are the ones responsible here, apart from other tasks such as counseling, physiotherapy, referral and linkages and others. Next, please. So as we can see, the program and uh, there is a policy, national policy for older persons, which was a brief document that outlined what the vision of the government was in terms of their policy. A decade or so after that policy came out, the national program was outlined that again focused on building capacity, because we did not have, to be frank, the capacity to manage older people because their needs are different. We did not have a specialized branch. We did not have specialists available. We didn't know what training would be needed for the medical officers at the PHC level, because they will be the main contact persons for them. And so even the operational guidelines of the service package at health and wellness center, they clearly mentioned that there is wide variation between the available infrastructure, the policies, the available HR, and the funds allocated between states. Like Parth mentioned, the problem of older adults is more and more challenging in the southern states, which has a relatively more aging population as compared to the northern states, where their priorities are different. But slowly they are also catching up. However, because of these local contextual differences, the program, the policy is very flexible, and they recognize the need that there is a requirement of piloting and research that we need to carry out before we allocate resources and before we scale up these proposed activities at the health and wellness centers. So these are not lines that are very rigid. These are just guidelines, and these can be adapted. These need to be adapted to address the local requirements of the states. For example, I'll give you one example. The program and the operational guidelines have clearly specified that ASHA workers need to screen older adults. How do they screen that? At what frequency? Who who will teach the ASHA workers? For what conditions will they screen? What are the questions they will ask, and what are the tests they will do? Because screening can include self-reported, screening can include some laboratory tests. So all those parameters are left open. We don't know. So there is a need for piloting. Do they use the same community-based assessment checklist of NCD screening that is being used currently for all adults? Is that suitable enough? Are ASHA workers competent enough to screen mental health diseases? If so, what are the questions they will ask? What are the tools they have? So these are the gaps in knowledge and gaps in evidence that researchers like we should be striving to answer. Uh, See, same case with the comprehensive geriatric assessment. The comprehensive geriatric assessment is a very vague term. If someone has not gone in depth into that, it's very vague and it includes everything and anything. But is that feasible? Is that feasible given the time constraints? Is that feasible given the resource constraints that we have? It's not possible to test for everything. Then what are the battery of tests in CGA that needs to be done? Who will do that? Who will interpret it? And that does not stop at assessment and screening. If they find some issues, how do you treat them? So there is a lot of scope for work that needs to be done before this can be scaled up. So these are all very wide ranging visions. The government is not planning to implement this in the next month or so. It's a very long program, and a lot of answers need to be found to questions before we can scale these up at the national level, because definitely these need to be scaled up, and this is a challenge that requires our fullest attention. So thank you for your patience today and joining. So that was all from my side, and I hope some points for discussion that we can have is we would like to throw this open to the available participants if they have any questions or if they want to discuss anything. Over to you, Parth.
Thank you for a very concise and very crisp presentation, sir. Like you rightly said, this policy, I was going through the operation guidelines, and it sort of is a combination of a lot of things. There is the role of NCDs, where the NPCDCS program comes in. They have included a lot of disability in this, with guidelines saying that there should be shoulder wheel ladder, finger exerciser. A lot of equipments specific to rehabilitation have also been included in the guideline. I also was very surprised to see that they have mentioned palliative care as well in this operation guideline, which again, we have a national palliative care policy, but we have never allocated funds for that policy, but we keep mentioning it. So that also comes under this policy. So it's a fusion of a lot of policies. But again, one thing is common in this is that, ASHAs are getting exploited all over again. And I think we are going backwards now, like how Gadchiroli ASHA workers sort of changed neonatal mortality by identifying and screening early, and now we are expecting them to do the same thing for elderly people as well.
So, Parth, I won't call it exploitation in the traditional sense. They are definitely overworked, and part of it is our failure as public health personnel and our planners to uh, optimize their workflows. So if they are visiting a household, they can complete many tasks instead of visiting the household multiple times. So there are ways of optimization that can take care of such type of overworking issues. And we have some evidence proving that ASHA workers are highly efficient. They are overworked. There is no question about it. The government also recognizes that, yes, they are overworked. And now the focus is how to get the best out of the limited time and effort that they can give.
Yes, sir. So I feel that's where digital health comes in, where a lot of ASHA workers have now been equipped with M-Health and various applications. But again, the issue is that there is no cross-platform functioning where they have to enter the same data for one program and then for another program. So I feel there are a lot of issues. Another interesting thing that I noticed in the guideline was for the PHC, there is no ECG machine, which is sort of essential equipment, even though the report itself says.
But is it? But is it? My question is an ECG machine an essential equipment at the PHC? If so, who will be the candidates who will be screened? Who will be taking the reading? And for what conditions? It cannot be an open-ended thing, right? If you put an auto analyzer, fully automated biochemical analyzer at the PHC, which some states have done, they are capable of running 500, 600 tests. But then the question comes, should they run all those tests in all the patients, or do we have some, once you have a very particular and specific objective of screening using ECG for such and such age groups with such and such history, then you will get an idea that is it required or not. Because yes, I agree, it may be required, but then does the medical officer there posted there have the competency to read ECG? And if so, if he reads, what does he do with it? Mostly they are not competent enough to read ECGs. So there are some gaps. First you have to address all those gaps, and at the end you put in resources into such. It's not that costly, I understand, but it is time consuming because you need a technician also.
Yes, sir, definitely, sir. So now the floor is open for discussion. These are sort of 3 points that we thought we should discuss at the end of this. First being, what should the general public know about elderly care in relation to policies and programs? Because I feel a lot of the policies are very perfect on paper, but the general public doesn't know about it. Just for example, the NPCDCS policy, the general public doesn't know that cervical cancer screening, breast cancer screening is actually should be done free of cost for them. So one of the aim of this forum is sort of connect the policy program with the general public through simple terms. So I think we can open the floor for discussion now by sort of addressing the first question. Anybody who would like to start off the discussion, go first.
Hello.
Yes, sir.
Yeah, good evening, Dr. Satri and Dr. Prasad. So, about the general public, we need to impart them the more knowledge regarding falls or frailty by containing campaigns, either through a social media campaign or through base level, community level campaigns.
Okay, rightly said. So, like you said, awareness campaigns to either social media or community level to increase the awareness regarding various public health issues. Is that what you mean, sir? Like regarding elderly care?
Yeah.
Okay. Radhika, you want to go ahead?
Yes. I think a major problem that is noticeable in the community is that there is a very little care-seeking behavior until symptoms get exacerbated to a point where daily life gets difficult. So when we talk about awareness, I think it's also important to encourage care-seeking behavior, because most people in India cannot afford to seek care unless it hampers with their daily life. And most problems the geriatric population faces are chronic. So they just think that they have to live with this. I think awareness campaigns should encourage routine screenings and make routine screenings more accessible and available in the first place.
Yeah, that's very rightly said. Care-seeking behavior is very poor, mainly because we ourselves not aware of, even as health professionals and even the patients and the general population, or what all difficulties the elderly population can face. Like, for example, the report mentioned that 1 in every 4 elderly complains of at least one ADL limitation, the most common being not able to use the toilet. So how many times as a doctor do we even ask that question when a patient comes to us or any elderly comes to us? So I feel generally the awareness is also poor in the healthcare professionals. And Akrushi has also mentioned in the chat, the message should go through the medium that this set of population use, which is also very important, because social media for somebody who's older than 60 years of age doesn't work.
So I can get a sense of the discussion that we need to improve awareness in the older adults. Now there are 2 specific challenges. You need to be more specific for us to be able to search for those answers. two specific challenges that I have faced, because this was my first instinct as well. Right, so maybe improving awareness about availability of services and schemes would improve adoption. That usually is not the case completely. The first challenge is like the previous speaker mentioned, normalization of the aging process. The older adults, most importantly, the older adults as well as their caretakers tend to get this feeling that yes, this is part of the normal aging process, and hence they tend to delay seeking care. Arthritis is considered a part and parcel of ageism, aging, and we need to. There is this feeling among the older adults that yes, for arthritis, what do? You go to a medicine shop and take some painkillers, and that's it. But what happens with chronic painkiller injections? There are other issues to consider, but that is one issue that I see. The second challenge is that we are under the National Program for Healthcare of Elderly, we are giving fixed day clinics. We are providing fixed day clinics for elderly people in CHCs. I have been to many such clinics trying to learn about their functioning. Mostly they tend to be empty. The reason being cited is that why does an older adult, why should an older adult come on a fixed day when the general OPD is open on all days? Now that is one um, barrier that we need to address while communicating as well. So communication strategies should tackle uh, ageism, should be age sensitive, that yes, what is healthy aging, we should be clear, this is healthy, this is not healthy aging, and you should seek care. One target of our communication should be that. The second one is we should try to find out reasons why specialized geriatric care um, clinics at the primary healthcare center are going unattended. So why is that? So we need to find answers for that. I can see some more
Yes, in the
points
chat
in
box.
the chat box.
So ageism, Preeti Sankaran says ageism is a factor we need to tackle. They need to understand that they don't need to suffer poor quality of life. And Dr. Rahul says very often medical personnel themselves are unaware what are normal parts of ageism.
Yeah, that is true.
Yes.
He's a
Dr. Rahul, you
geriatrician,
were
I think,
raising your
and
hand.
he's right. He's right.
If you want to just unmute yourself and speak.
Yeah, I mean, I just want to reiterate what the other people was saying, that most doctors are unaware about what is a normal part of aging. Sometimes where do you draw the line and realize that this is actually a pathological process that needs an intervention. So before we actually get into a social awareness about into the general public, medical personnel themselves needs to be they need to be having at least a bird's eye view of what goes into geriatric care. Because what happens when you don't pick up these things early, they come to a doctor at a much later state, at a more advanced state, where interventions and management is going to be even more difficult and sometimes impractical to pursue as well.
Yeah, our MBBS curriculum is also not well versed and well suited to cover these aspects. I mean, we were never taught about healthy aging. So that is one gap. That's why there is a gap. So that gap needs to be filled. Rightly said so, Dr. Rahul.
Yeah, because sometimes what happens is that people do not pay much attention to functional status of the patient. So sometimes when the CRP of the patient is fine, they say the patient is cured and they send the patient back home. But sometimes the patient came in walking, is now being in bed for so many days, cannot walk anymore. So you need to correct that before you send the patient back home. Just because the CRP is fine, you can't send the patient back home. So that kind of awareness is very important to be amongst the medical personnel.
Yeah, definitely. Even I worked for 1 year in emergency, and even I felt like, most of the elderly usually come with the complaints of low appetite to begin with. And that is a very non-specific complaint, easy to ignore. But I sort of learned from few mistakes, and I realized that that loss of appetite and like slight change in sleep wake cycle is very like sort of very critical in these elderly people. Maybe a
Exactly.
UTI, maybe just constipation, but it's something we shouldn't ignore.
Exactly.
We also have Monmita, who is a social worker. She's from a social work background, and she's saying that geriatric care in India is actually a very new concept. And she learned that geriatric care as such is very poor, and people think it's a part of the life cycle. Dr. Sudeep says that geriatric care actual implementation at the ground level is lacking. So anybody who was experienced with geriatric care at the ground level, anybody who wants to share their experience of what is actually happening on ground? The policy seems almost near perfect on paper with few flaws, but is it really happening? Because 1999 is when the national policy for older persons actually came out. It's been almost more than 20 years now. So on ground, what is the reality like? If anybody wants to share.
So part the policy was mainly not only focused on health, it was also focused on social affairs and some other accessibility related challenges. But the real start of geriatric care in India was the program, National Program for Healthcare of Elderly. So there were two broad components of that program. One was the capacity building component, where we have done fairly well. We have established medical colleges offering MD courses. We have had trainings of medical officers. Many states have trained them. There is a provision for specialized clinics that are being set up, that have been set up, and the infrastructure is now fairly good, at least in the few states that I am acquainted with. The infrastructure part, the HR part is yet to catch up, definitely, like in almost all aspects of public healthcare in India. HR will be a challenge in a country of the size of India. But we started from where we started. We started at zero, so we are catching up. We are increasing the HR capabilities as well. The real gap now is providing the pathways, providing the tools for effective implementation of that program. So that is a fairly recent thing. I mean, these operation guidelines are of 2021 or 22, I think. These are not that old, and this has not been adopted in the states. They are being tailored, and they will be adopted in the coming uh, CHO trainings, but they have not yet been fully adopted. So there is still a lot to do. We have done something, but there is still a lot to do.
Okay, so just to summarize of what the discussion has happened so far, I feel the 5 points that came out that the general public should know about is, firstly, we have to talk about normal aging, what it seems like with the general public. We have to tell them that small things like loss of sleep or appetite is not normal. So that has to be conveyed firstly to the general public and also to the healthcare professionals. Other thing is this also comes along with improving communication with our sort of general population. Don't have fixed day clinics is something that the public health professionals have to focus on.
No, we can't say don't have fixed day clinics, but we should try to find out why the attendance in fixed day clinics is poorer as compared to routine clinics.
Okay,
and we have to find answers to those questions.
And possibly having some slot in everyday clinic, will that be useful rather than just having one dedicated day? Akrushi, please go ahead. Please unmute yourself.
Before she goes ahead, Sandhya has asked about elder abuse. Yes, elder abuse is a big challenge. So what we have in India is a lot of research on older adults. So that there is no dearth of data on older adults. Large studies, including a longitudinal aging study, which is fairly significant in sample size. It gives us good quality data. So data is not lacking, and multiple data points show that elder abuse is a challenge. Yes, and elder abuse in the community, detecting elder abuse in the community is not that easy because of the social and cultural connotations to it. But this comprehensive geriatric assessment includes a screening for elder abuse. There are some battery of questions that can be asked to classify older adults at risk of elder abuse, or uh, who have a higher risk of elder abuse. So that is available, and that is being planned at the community and the health and wellness center levels. Go ahead.
Yeah, Akrushi, please go ahead.
Yeah, thanks, Parth. Thanks, Jay. I just wanted to add something to what Jay has indicated on the capacity building part. So, Jay, you have mentioned that now we have come up with MD geriatric medicine courses in multiple medical colleges, but still, they are not, that I would definitely use the word popular amongst the medical fraternity, as it will be like how much we care about our MS or MD in general medicine, but it doesn't stop there. What about the curriculum modifications and the add-ons to other professionals who are equally important, if not more or less, to elderly care? For example, physiotherapy. A lot of mobility issues happen in once you cross a certain age, and it also depends upon how active you have been physically, and what all stresses and what has been your life course. So I'm not aware about any modifications in the physiotherapy curriculum, or nursing for that matter. Honestly, I'm definitely not aware if something has changed, because if it has been throughout this years, even after getting MD in geriatric medicine into picture, are we even thinking about changing this curriculums and getting this new perspective in their curriculums as well, and in their trainings? Because I feel it is extremely important to make this set of health professionals also aware about this population, which generally suffer silently. So that is my take on the capacity building part. Yes, we have walked a few steps, but I think there are miles to go as well.
Yeah, I
Thank-
agree. I agree that the popularity of the courses is not there, but that is the second step. The first step is availability of the courses. For over 50 years, we did not have the course itself. I personally feel, as a public health practitioner, the best course would be MD in family medicine. These will be the best guys to be posted at the PHCs. But the availability should be the first, and then comes the popularity and all. So availability is there now, and slowly the availability is also very limited right now. Once it gets increased, then the popularity issues, these issues will be there. All branches are. This is a personal choice whether someone wants to what branch someone wants to pursue. But on the second part, I wholly agree with you. Our curriculum needs change. Even the recent updated competency-based training in MBBS is silent on geriatric care, is silent on many such issues related to geriatric care, not just geriatric care, but issues like requirement for physiotherapy, the concepts of frailty. These are all that need to be included in the curriculum. I agree. But for that to happen, we need some background work to be done. Building a curriculum suitable for inclusion into the training programs is a time consuming and challenging task. If we want to include these aspects, now we have multiple questions that we need to find answers to, and those answers will be given by medical educators. So in which year we want to include it. Do we go for horizontal integration, or do we go for vertical or system-based integration of these concepts? Which subjects will cover this, and what parts will these subjects cover? So all these, if we have this information, then we can advocate for inclusion. But yes, this is sorely lacking in both the MBBS and the nursing curriculum in India. I agree with you wholly there.
Thanks, Jay. Parth, I also had a request. If we have anyone who has practiced as a medical officer in any of the PHCs, it would be great to hear their thoughts as well, because the scenario in the rural settings would be very insightful to hear about. So it's just a request if anybody else is there and would like to share their thoughts on what we are discussing.
Yeah, definitely. Anybody who wants to sort of pitch in, share their experience.
So before others pitch in, I'll share my experience. I'm not sure how it is nowadays, but a few years back, almost a decade back, when I pursued my PG, there was a gap of around 9 months between the examination and the actual joining. ये counseling ये सब चलता था. So in that time I joined one super specialty hospital in an urban setting in Odisha, Apollo Hospital to be frank. And there I worked for 3 months. I saw a lot of, I did some residency type of work and some documentation, all those things. I saw a diverse field of patients from neurology, cardiology. Then I tried my hand at PHC in a coastal region of Odisha. There again, I saw a different cohort of patients, different type of patients who were coming there. And lastly, I have worked 3 months in a tribal, backward, inaccessible PHC. And that experience was also very different. The patient that comes to, let's say, a super specialty corporate hospital is nowhere similar to someone who comes to a public healthcare facility. And again, there is differences between the public healthcare facility of a coastal region and the tribal and backward regions. Now, the most I saw geriatric patients, and from where I picked up my interest in geriatric healthcare, was in the coastal PHCs. Majority of the patients attending there were older adults, and they came there out of convenience. They did not come because of lack of options. They came out of convenience. The majority of patients in tribal and backward areas were infectious disease patients, children, maternal cases, all those things. So geriatric care seeking was very poor in those areas. Mainly, I would attribute it to the inhospitable terrain and inaccessible nature of our health system in those regions. But the best experience I've had is a PHC in a rural setup in a coastal, well-to-do. It's not a poor coastal region; it's a well-to-do region where everyone who needs some specialized care will go to a nearby medical college because it was available. But the older adults had time, they had patients, and they would come fairly regularly to get a refill of their medications. They would spend time asking for injections. I don't know why, but there is this feeling that injections work better than medicines. That's throughout, that's universal across India, I feel. Yeah, so that was my experience.
So I have a sort of experience myself, having worked in emergency for a year. The one thing which was strikingly common, which I felt in elderly population, was a lot of suicides used to come during that period of 1 year when I was there. Mainly maybe because COVID sort of exaggerated that thing. I am not sure why it was happening. But a lot of the patients, when I sort of talked to them, something I noticed was chronic pain was cited commonly as a reason for them to sort of, attempt deliberate self-harm. And now, because I'm doing my MD in community medicine, I have been to PHCs for the past 1 month. And here the sort of complaints are totally like they sort of match, which there are a lot of people coming with chronic pain. There are also NCDs, but most of those pains are, non-specific. I can't obviously diagnose them with psychosomatic because it's just like Kavan Kumar is saying, it's generalized weakness, sort of non-specific pain. Could be psychosomatic, could be just loneliness presenting as pain. But yeah, this is what my experience has been so far. I think the second question is already answered, which is on the screen. What the public health professionals should know about this program. A lot of points actually came out that capacity building has happened over the past decade. MD program has started, but it's not the first priority. As you know, I'm hoping this sort of forum, when it goes online, because we are recording it, I'm hoping it will help in increasing popularity of MD in geriatric medicine. Infrastructure has improved, but human source for health are yet to catch up. And I feel one of the most important things that came out was there is need for transdisciplinary sort of collaboration with physiotherapists, nurses, and everybody's curriculum sort of modifying based on the need. And that brings me to the last question. What do you think are the research gaps in elderly care in India? I think one was already pointed out by Dr. Shatri, that pathways and tools that are needed for the implementation of this sort of operational guideline which has come out, that's something which is needed. What is the best way to do in which part of the country? Because that's also another issue. Tamil Nadu will have a different problem and different way of sorting it, whereas UP will have a different problem. So that's something which research can answer. Any other ideas people have in this group? This group also.
So we need a significant amount of work on frailty in the coming years, because that is an aspect that our evidence is entirely dependent on that comes from the West. So we need very indigenous solutions to identifying frailty. We need solutions to address frailty. The term that we are listening from others today also was generalized weakness. That is a manifestation, that is a physical manifestation of frailty. So ways of identifying and addressing frailty is something that needs work. I mean, there are endless gaps in research or gaps in evidence if you come to think about it. But what will give us the best returns on our investment is the crucial point. I feel, for example, let's say we are aware that elderly population is increasing. So what will be the so some modeling exercise where we can estimate the costs related to this increase elderly population, costs on the health system, costs on the economy of the country as well, and whether if we include adult immunization programs, older adult vaccination, whether that will reduce mortality in these older adults. Now, these are modeling exercises that can be done easily, and these have been informing our vaccination policy. For example, in COVID, these were the models that informed us who will be given the vaccine on priority. So we can take up such mathematical modeling to answer to see the feasibility and cost effectiveness of older adult vaccination program, because community acquired pneumonia is still the largest cause of one major cause of death in these age groups.
Yes, actually, those are really important topics that you have sort of shared. I just wanted to say that this sort of platform also gives you an opportunity to like collaborate with people who are in here, or if you just want to like sort of want me to link you up with somebody who would be interested in any research project, the clinical project, or sort of modeling like just suggested. So that's also something I can help with. Anybody has anything else to share? Otherwise, we can close for the day. I think it's already been 1 hour. Yeah, definitely. That's also a great thing. I think I didn't let anybody introduce themselves. So if anybody wants to introduce themselves, they can also go ahead, please. Kavan Kumar sir, if you want to go ahead first.
Hello.
Yeah, you're audible. Please go ahead.
Yeah, I am Dr. Kavin. I did my MD in Community Medicine from GMC Nagpur. And currently I am working as a AP in a medical college institution. And my interests are with gerontology and with palliative care services in geriatrics. So I'm just exploring this field of interest and yet to collaborate and speak with more people. Probably Jay Satri sir will be a key person guiding me in this perspective.
Thank you for sharing that, sir.
Thanks. Thank you.
So palliative care in elderly is again, that's something even I'm interested in. I'm interested in palliative care in general. But palliative care in elderly is just, it's another huge field to deal with. Anybody else who wants to just sort of introduce themselves so that it's easier to collaborate later, talk about their interests? Otherwise, we can sort of move on to the last session, which is, so this is our email ID. I'm sure you already have it. In case anybody wants to write to me, wants me to link up with somebody else who's there in this chat, please feel free to write an email to me and I'll get back to you. And the last part is feedback. Any comments, anything we can do next time to sort of improve the session, something you were expecting out of this, but you didn't get. Anybody wants to say anything or any compliments are also fine.
Yeah, I just
so
wanted to
Parth,
thank you and Jay. Thank you so much for sharing your insights, and it was really helpful. A lot to learn. Thanks for your time and efforts, which would have gone in the background. Thanks, Parth, for initiating this, and thank you everyone for patiently listening. Thanks, and it's a great start, Parth.
Thanks a lot.
Honestly.
Thank you so much.
Great work, Parth. Continue encouraging such activities. I think it will take some time, but we need to stick to our guns. My suggestion is to build a website. It doesn't take much resources or effort, but I think a website where you can actually hyperlink all those all the discussions that we are having, all the materials that you can share, as well as some blog posts that some of the members may be interested in. Posting those would be nice on those.
So
I
we
can see
already
you
have
have
a
a
website.
website. Then I would suggest use the website's email because you're using Gmail. I think the website allows to have an email domain.
Yes, sir.
So
Yes, I
had not gone through the website, so let me have a look, and others can also have a look and suggest feedback. Always be open to feedback, and this is great that you ask for feedback. Always be open to constructive criticism and feedback. It only improves you. So
Yes,
good
sir.
luck, good initiative, Parth. Keep it up, and I'll be happy to join in the next one as well. Great work.
Thanks a lot, sir. Thank you for presenting today. Actually, this is all on volunteer basis, and Dr. Shatri actually agreed to do the first one. So thanks a lot for that. We'll be having our next forum next month. It's going to be once a month thing. And I have actually already decided who's going to present next. So that's something I'll share soon. And I'm hoping we learn a lot from that as well. So I just want to thank you all for joining today. And I hope to see you next time as well.
Thank you. Bye.
Bye. Thank you all.
Bye.
Bye.